Good evening, everyone. Thank you for joining in for today's Nomic webinar session. We are very thrilled to have each and every one of you joining us tonight. It's my pleasure to introduce our speaker for today, Dr. Aarti Darra, who will be speaking on homologous recombination deficiency. Dr. Aarti is a bioinformatician working at Karkinos Healthcare with a special focus on the research area of cancer genomics. She has pursued her doctorate from CSI Institute of Genomics and Integrative Biology in New Delhi, where her work focused on investigating small intestinal health in hyperglycemia in collaboration with PGI Chandigarh. Her PhD work was actually recognized extensively, and she was also awarded the prestigious Young Investigators Award by the Indian Society of Gastroenterology in 2022. Currently at Karkinos Healthcare, her interests extend beyond developing clinical genomics workflows as she works towards harnessing genomics insights for early detection and diagnosis of cancer. So, without further delay, I'll pass the virtual stage over to Dr. Aarti. The floor is all yours, Dr. Aarti.
Dr. Bani, for your kind introduction. Today we'll be talking about a very relevant topic called homologous recombination deficiency. I'll be sharing my slides. Are the slides visible?
Yes, Dr. Aarti, go ahead.
Okay, thank you so much. Yeah, so today my name is Aarti Darra. I'm working as a bioinformatician at Karkinos Healthcare based out of Bangalore. Today, the topic of discussion is homologous recombination deficiency. We are in the era of precision medicine where the goal is to determine the effectiveness and safety of therapies which match to the treatment as per the biology for which it is defined. And to accomplish this, we rely on molecular characteristics that could help us in diagnosing, providing the prognosis, or providing the safety of the intervention. And these molecular characteristics are called biomarkers. Biomarkers are objectively measured and they provide us the indication of a normal biological process or a pathological condition. Now, one such biomarker is homologous recombination pathway, also known as HRD. So when a normal cell divides, it replicates its DNA. And a cell has a number of non-overlapping redundant pathways called surveillance mechanisms that ensures that the copied DNA is very similar to the original DNA. But when these surveillance mechanisms become defective, it leads to accumulation of more errors, more alterations, finally leading to the malignant transformation of normal cells into a tumor cell. And this is one of the hallmark of cancer. This is very popularly known by a term called genomic instability, wherein a cell has accumulated number of alterations transforming into a tumor cell. And as I already told, a cell has multiple redundant non-overlapping pathways to repair the errors. And these pathways are broadly categorized into 4 categories. And of these 4, the double-stranded DNA, double-strand break repair is the most cytotoxic lesion. A cell has 2 different mechanisms to take care of repairing the double-stranded breaks. One mechanism is a high fidelity called homologous recombination pathway, and the other is the non-canonical alternative pathway called the non-homologous end joining, and this pathway is an error-prone pathway. So explaining the differences between the 2 pathways, when we speak about the homologous recombination pathways, when we speak about the homologous recombination repair, it starts with the resection of the DNA to create the 3' single-stranded overhangs, which is not the case with the non-homologous end joining. In non-homologous end joining, the ends are mostly protected from resection. Moreover, this homologous recombination pathway, it is active only during the G2 and S phase of the cell cycle because it is dependent upon the sister chromatid for repair. Whereas when we talk about the non-homologous end joining, it is mostly active throughout the cell cycle because it is not dependent upon the template to repair. Now, because the non-homologous end joining is not dependent upon template, it introduces lot of insertions and deletions within the genome, creating a condition which we discussed called genomic instability. This homologous recombination pathway will be the major topic of discussion in this presentation. This pathway is a very complex pathway and is a slow process wherein multitude of proteins are involved at different steps, right from sensing the DNA double-stranded DNA damage. It starts with the proteins called ATM, ATR, and CHEK1, followed by cascade of signaling events wherein multiple protein complexes come together to finally repair the double-stranded break. Around 30 proteins are involved in homologous recombination pathways, of which the role and mechanism of BRCA1 and BRCA2 is comprehensively studied and is very well known. And in a study of around 17,000 solid tumor specimens, it was found that the other proteins which are involved in homologous recombination repair and are highly mutated are mostly ARID1A, ATMs, CHEK1, BRCA1 and BRCA2, RAD51, and PALB2. So basically, what we understood from this is that HRD is basically a phenotype wherein a cell has become incapable of repairing the double-stranded breaks using the HRR pathway. And there are multiple causes of the homologous recombination deficiencies. The first one is the genomic perturbations which are introduced in the HRR pathway genes. So as already mentioned, that the BRCA1 and 2 are most comprehensively studied, and it is found that 1 in 2 patients with ovarian cancer are HRD positive, and 1 in HRD positive patients have BRCA1, 2 mutations. And the nature of these mutations could be somatic and germline in nature. But there could be germline or somatic in nature. Now, BRCA1 is approximately 1800 amino acid long protein, which has multiple domains to interact with various proteins. At the amino terminus, there is a ring domain, which is followed by an unstructured region, followed by a coil structure, and finally with BRCA carboxy repeats. The major role of BRCA1 in homologous recombination pathways is to generate the 3' overhangs and then load the RAD51 recombinase onto the single-stranded DNA. Let's talk about the BRCA2 protein. BRCA2 protein, in addition to interacting with the PALB2 protein, it has various domains. The central ones, BRC domains, they interact with the RAD51. It also has a highly conserved DNA binding domain too. Now, other than the mutations in BRCA genes, which are predominantly known as the major cause of HRD, the mutations in non-BRCA genes could also play an important role in causing the HRD phenotype. Now, because there are multitude of proteins, not all proteins are very well studied with respect to HRD pathway. And it is found that the homozygous deletions in CHEK1 and PTEN leads to high HRD-associated LOH scores. Moreover, mutations or methylations of RAD51 were associated with long-term responses to treatment. Another cause of HRD when it comes to genomic perturbations is the epigenetic modifications of HRR genes. Again, these modifications are seen in mostly 2 genes, BRCA1 and RAD51, wherein the methylation of the promoter of these genes leads to their silencing. And it is seen that the BRCA1 methylated as well as the RAD51 methylated, they harbor the high HRD scores. And in a recent study of TCG samples, it was found that the epigenetically modified HRD cases have poor prognosis similar to the HRD negative. Another, so we talked about two pathways of repairing the double-stranded breaks. When one fails, the cell is forced to follow the second one, and using which the consequence of using the second pathways introduces introduces a consequence called genomic instability, which is measured by different parameters. So if in case a cell has intact BRCA1 and BRCA2, then it uses the homologous recombination pathways and the genomic integrity is maintained. But if in case the cell is deficient in repairing the double-stranded break using homologous recombination pathway, it is forced to use the alternative pathway called non-homologous end joining, which leads, because it is an error-prone pathway, is introduced lot of errors. It leads to genome scarring, which is basically measured by three parameters: LOH, LST, and TAI. Now, LOH is a condition in which one of the two alleles of a gene are lost, which results in a homozygosity at that genomic site. The second parameter, which is used in genome scarring, is the TAI, called telomeric allelic imbalance. It basically indicates that the proportion of genes at the end of the chromosome are absent in one chromosome and it's present in the other chromosome. And the third pattern associated with genome scarring is the LST, large scale transitions, which basically refers to allelic imbalances of greater than 10 MB between adjacent genomic regions due to translocations or copy gain losses. Now, these three parameters are previously been well studied, and these three parameters in patients with known BRCA1 and BRCA2 mutations. These three parameters, LOH, TEI, and LST, are highly correlated with the BRCA1-2 deficiency and as well as with the platinum sensitivity. Moreover, these three parameters are independently correlated with each other also. For example, if you see the bottom left panel, the correlation top right panel, the correlation coefficient between the LOH and TAI is around 0.78, whereas when it comes to correlation between LOH and LST, it is 0.78, and finally TAI and LST are correlated at a coefficient of 0.65. In spite of these three parameters being independently associated with BRCA1-2 deficiency, it is seen that when these three parameters are combined together, they provide a better prognostic value than the individual components. And when we combine these three parameters, LOH, LST, and TI together, it is known as genomic instability score. Now, to interpret HRD, it could be either the cause or it could be either the consequence. When we talk about causes, we talk about the mutations in the HRR genes, the BRCA-ness phenotype, and the genomes and the epigenetic silencing. Or when we talk about the consequence, it could be the genomic instability score. So in either of the condition, for example, if in case only germline BRCA mutations are present, it is conferred as HRD positivity, or if in case only somatic BRCA mutations are present, it is conferred as HRD positivity. And only if GI score is greater than 42, it is also conferred as HRD positivity. Now, when we talk about the somatic mutations in the BRCA1-2 genes, there are chances that these mutations could also be reversion mutations, which means that they would restore the HRR function and resume its functionality. So if we are looking at somatic BRCA mutations, we need to also check at the reversion mutations in BRCA1 and BRCA2. The major in BRCA1, the reversion mutations across different cancer types is mostly present in exon 10, whereas in case of BRCA2, the reversion mutations across different cancer types are present in exon 11. Now we understood that the homologous recombination deficiency is also known as HRD positive. It could be germline or somatic mutations in BRCA1 and 2. It could also be the BRCA-ness phenotype, which is mutations in non-BRCA genes. And when these these HRD phenotype patient samples, they are sensitive to a drug called PARP inhibitors, which we are going to discuss shortly. And also the genome scarring more than 42 also confers HRD positivity. And in samples which are not HRD positive, they are called homologous recombination coefficient. This is the term which needs to be incorporated when we talk about the HRD status. So how this HRD is used in clinical decision making? There is a subtype of ovarian cancer where HRD has emerged as a biomarker for both predictive and prognostic value. And 50% of this subtype, which is known as high-grade serous ovarian cancer, they show HRD positivity. Now, when we talk about a prognostic marker actually informs about the cancer outcome independent of the treatment received. And a predictive biomarker provides the likelihood of a response to chemotherapeutic intervention. For patients who are HRD positive, for their treatment, PARP inhibitors are approved by European medicines agencies and by FDA for management of high-grade serous ovarian carcinoma in different clinical settings. These PARP inhibitors are approved as first-line maintenance therapy to treat women who had a complete or partial response to the most recent treatment with chemotherapy. It is also used as a second-line maintenance therapy for platinum-sensitive relapse disease. And it is also approved as a monotherapy treatment for high-grade serous ovarian carcinoma with a BRCA mutations or a positive HRD test after 2 lines of therapy. Now, these PARP inhibitors have been approved at different time scales, starting with the olaparib. Here, the blue ones are the ones which are approved by the EMA, and the green ones are approved by the FDA. Eventually, as you move from 2014 to 2020, you will see that not just a single PARP inhibitors is being used, but eventually it has led to a combination of PARP inhibitor with another drug called angiogenic agent, which is called bevacizumab, because eventually with PARP inhibitors, these resistance the resistance has already been seen, which is being taken care by the angiogenic agent. So when we talk about the usage of PARP inhibitors, how does it function? PARP inhibitors, the mechanism of PARP inhibitors is mostly using synthetic lethality, which is a mechanism wherein when we introduce 2 conditions in a cell, it is forced to die. For example, when a cell is deficient in repairing using the homologous recombination pathways, introducing PARP inhibitors would ensure that the single-stranded breaks are also not repaired, which eventually lead to which eventually convert to double-stranded breaks and leading to accumulation of double-stranded breaks and eventually the apoptosis of the cell. So HRD, knowing the status of the HRD provides a predictive value for the response to platinum-based therapeutics or PARP inhibitors. Moreover, it also provides the status whether the treatment would have a better prognosis by providing with a better progression-free survival or overall survival than HRD negative, and hence HRD also is a prognostic marker in ovarian cancer. Now, FDA has approved 2 commercial tests for the assessment of HRD. has approved many commercial tests for HRD assessment. Here we'll be talking about the two major ones. One is by My Choice Companion Diagnostics, which is also known as MyDR assay. This it relies on a proprietary score of genomic scarring, which is again the sum of LOH, LST, and TAI. And using a threshold of 42, using a threshold of GIS as 42, HRD positivity is conferred. This test also provides us with the status of BRCA1 and BRCA2 mutations and the mutational rearrangement. The second one is the Foundation 1 companion diagnostics. This does not include genomic scarring, the sum of the genomic scarring or the genomic instability score. Rather, the positivity is confined by if the loss of heterozygosity is greater than 16%. In addition to that, it also provides us the profiling of 315 cancer-related genes and the mutational status of BRCA1, 2 genes along with the other HRR-related genes. Now, we already talked about the HRD testing methods. The first being the genomic aberrations, which is evaluating the mutations in the HRD pathway. Second is evaluating the genomic scores, of which one we have already talked about called genomic instability score. There is one more signature, which is a biomarker of HRD called signature 3. This mutational signature is based upon single state substitutions and is associated with BRCA1-2 deficiency. It is characterized by high number of large deletions with overlapping microhomology at breakpoint junctions. And it also correlates with the prognosis and response to platinum therapy in high-grade serous ovarian cancer. One of this assay which uses this signature is called HRD Detect. It relies on whole genome sequencing data. It uses an algorithm wherein it calculates 6 HRD associated signatures, which are predictive of BRCA1 and 2 deficiency, and takes the sum of it. Interestingly, HRD Detect has a sensitivity of reaching to 100% in BRCA1-2 null cancers, whereas for the sensitivity of the genomic instability score is just 60%. Apart from the genomic-based assay, there is another layer of HRD testing called functional measures of HRD, which relies on visualizing the RAD51 foci. So in normal cases, when the BRCA1-2 mutations are not there, after creating the overhangs, the RAD51 protein is uploaded and it creates a filament. But if the cell is defective for the BRCA1 and 2 mutations, it has become incapable of forming the RAD51 foci, which attributes the functional phenotype. Now, the pros of this method is that it can actually overcome one of the limitation of genomic scar methods, which is to evaluate the presence of acquired reversion mutations. But using this test in a clinical setting, this has its own challenges. To implement HRD in clinical settings, ESMO has provided guidelines wherein the germline and somatic BRCA1-2 mutation testing is recommended to identify the patients who would qualify for PARP inhibitors. And also a validated scar-based HRD test can be used to understand the magnitude of benefit which BRCA wild-type patients will get from the PARP inhibitors. Along with that, the validated SCAR-based test can also be used to evaluate which patients are least likely to get the benefit. And also in platinum-sensitive relapsed maintenance settings, the PARP inhibitors could be considered, the HRD test could be considered for evaluating the risk and benefits of the PARP inhibitors. We understood the clinical relevance of HRD, which is that it is an FDA-approved biomarker for ovarian cancer. This biomarker is prevalent across different cancer types, around 17% across different cancer types like breast cancer, pancreatic, prostate, and ovarian. It is also a predictive and prognostic biomarker for platinum-based chemotherapeutics and PARP inhibitors in high-grade serous ovarian cancer. So before we end up this presentation, I would like to introduce that there are still challenges in which the HRD is defined, measured, and reported in clinical settings. So when it comes to defining HRD, there are different definitions which are used when it comes to scientific community or medical community. There are terms called BRCA-less, BRCA-like genome scarring, which are used to depict the HRD. But there are still confusions, so much so that sometimes there are misaligned definitions, and the mutations in HRR genes are often used interchangeably with the HRD phenotype. Next, when it comes to evaluating HRD in routine clinical practice, there are again various challenges. For example, you can see here these are the clinical trials where the HRD phenotype, where the different methods for HRD testing were used with different drugs. So, for example, in the clinical trial called VILIA, um, when it comes to evaluating HRD in clinical practices, there are different methods which are used in different clinical trials. For example, in clinical trials like SOLO, wherein the germline or somatic BRCA1-2 sequencing was used. But in case of PRIMA, Myriad, MyChoice, and in the case of Paola, Myriad, MyChoice assay were used. But later on, when it comes to Ariel 2 and 3, the different assays which were used called the LOH, which was exceeding 16% or 14%. Moreover, in one of the clinical trial, there is a new method wherein the combination of PARP inhibitors is being observed with the immune checkpoint inhibitors. They saw that none of these methods were correlated with the treatment response. Rather, the genomic signature called signature 3 actually correlated with the clinical benefit. So evaluating HRD in clinical practice needs more streamlining. Next, coming to the understanding of the genes which are non-BRCA in HRR pathway is still in an infant stage and requires a thorough investigations across different cancer types. Last is how this HRD cutoff of 42 is being evaluated. For example, again, in different cancer types, in different clinical trials, for example, in VILIA, a cutoff of 33 was seen as conferring the HRD phenotype, whereas in the other two clinical trials, PRIMA and Paola 1, the cutoff of 42 was evaluated as conferring the HRD phenotype. So I'll stop here and I'll be happy to take up questions.
Thank you, Dr. Yati, for that very insightful talk. The floor is open for questions for the audience. I request everyone to either drop in their questions in the chat box, or you can ask them directly to Dr. Yati also. While people go ahead and ask their questions, I have one question for you, Dr. Aarti, if you don't mind me asking. Is there a way that HRD can be reversed or compensated by other pathways?
Normally, a cell has already a mechanism uh, for compensating for the deficient HRR pathway called non-homologous end joining. And to take care of the reversal, there could be uh, mutations which could result in restoring the HRR functionality. and they would also be providing resistance to the PARP inhibitors.
Okay, thank you. So, we have a question from Carolyn. Can you explain again signature 3 and its clinical utility?
Mhm. So signature 3 is used, which employs the whole genome sequencing data. It actually is a combination of 6 different signatures, which included gains and losses. And I don't remember these 6 signatures, but it is a very comprehensive profiling of HRD, and the clinical utility extends to evaluating the HRD phenotype in a more sensitive manner. And the sensitivity of this method actually is far better than the available methods. Its use in it is a costly method. Its use in clinical settings is still in a preclinical stage. So commenting upon its utility in the clinical setting is very early to comment on.
We have another question. What is the difference between HRR and HRD testing, and are they done using the same protocol?
Yeah, so as I clearly mentioned, there are misaligned definitions of HRR and HRD. HRR basically stands for homologous recombination repair. It is a pathway, it is not a test. It includes multitude of proteins which could form one of the cause of HRD. Whereas when we talk about HRD, it's a phenotype which confers the cells incapable of repairing the double-stranded breaks, and it is actually a test which is evaluated using different methods, right from evaluating the BRCA1-2 mutation status to genome scarring score.
We have another question in the chat box. Is there any physical test through blood source available for this, or the genome sequencing is the only option?
Uh, we can evaluate the cause of HRD using the BRCA1 and BRCA2 tests, which is using a blood test. But there are cases when even the absence of BRCA1 and BRCA2 mutations could confer the HRD phenotype. And to reach to that conclusion, genome sequencing is mandatory, because most of the because HRD phenotype is not just the deficiency of the BRCA1 and BRCA2, it could also be deficiency in the other HRR related pathways.
What are the current challenges in accurately detecting HRD in clinical settings? And I think you can take this up in two pieces. What are the current challenges and what are the current advancements that are needed to enhance the sensitivity and specificity of assays for HRD?
Okay, so the first one is current challenges in HRD.
Yes, current challenges in accurately detecting HRD in clinical settings.
Okay, accurate. So different laboratories have evolved different methods based upon uh, the resources. It's a resource dependent approach to calculate the HRD. Um, the in clinical settings, normally there will be very advancements in calculating the HRD scores. Uh, Not at this time point, we are mainly FDA has to approve 2 tests for calculating the HRD score phenotype using the My Choice and companion diagnostics. But depending upon the availability of resources, different companies have relied on different methods for calculating HRD. For example, one of the most recent methods that is being used is the LOH, independent of the other measures of the genome instability. So we would expect a lot of advancements in the usage of HRD in clinical setting. And the second part was,
Yeah, the second question is, what advancements are needed to enhance the sensitivity and specificity of diagnostic assays for HRD associated phenotypes to improve patient stratification and treatment of outcomes?
uh, so this could be answered in three pointers. First, uh, the investigation of roles of different of the other HRR genes needs to be investigated thoroughly. Second, there are mechanisms of resistance which should be investigated uh, along with the HRR pathway genes. And the last could be that the combination therapies should the clinical trial should be organized with combination therapies in order to evaluate the HRD phenotype.
Another question from the chat box. If a patient comes for BRCA1 and BRCA2 testing, should they be recommended to do the HRD panel also?
Depends. If in case there is, so normally the somatic BRCA1 is preferred for understanding because the germline BRCA testing would also be accompanied by the genetic counseling, and it also adds a societal pressure. Normally, based upon the status of the BRCA1 and BRCA2, decision to calculate the HRD using the other alternative approach will be taken up.
Yeah, thanks, Dr. Aarti. If there are any more questions, please feel free to drop them in the chat box.
I don't think there are any more questions.
So I think I'll go ahead and ask one more then. So HRD, in your opinion, is it a strong therapeutic biomarker or it will be useful for diagnostic and prognosis as well for different types of cancers?
Yeah. So currently, the prognostic and the therapeutic efficacy of this biomarker has only been evaluated in the high-grade serous ovarian carcinoma, but more other cancers which show the HRD phenotype include the breast, pancreatic, and prostate, wherein the efficacy of this as a biomarker is still in an investigational stage.
Okay, thank you. So I guess if there are no more questions, thank you, Dr. Aarti, for that very insightful talk, and thank you all for joining us tonight. And yeah, okay, I think we have one more question coming up in the chat box. So we can just take that up. Yeah. So if a patient wants to know about a hereditary cancer test, which is the best test that you would recommend?
In case of hereditary cancer type, the patient can go with either the panel sequencing because there could be contribution of any gene or the whole exome.
Okay, so thank you for that answer, and thank you, Dr. Arti, for your very informative talk. And thank you all for joining us today. Your engagement and participation make this webinar series truly valuable. And before we wrap up today's session, I would encourage all the participants to post if their questions are still left unanswered on our YouTube channel. And we also value your feedback and suggestions. So take a moment to share your thoughts through the survey link that we'll be sharing with you shortly. Looking ahead, please mark your calendars for our next webinar on 1st of June, where Dr. Shuvro Sankar Datta will enlighten us on red cell genotyping in clinical practice. Once again, thank you all for your active participation today, and we look forward to seeing you at our next webinar. Thank you.